This is Module 3. Module 3 goes with Exam 3. Module 3 has two parts, and Part 1 is on the conduction defects or disturbances and heart blocks, and Part 2 is on dysrhythmias. And these two parts will go toward Exam 3, which I'll review, do a slight review for, a little bit of a review for toward the end of this module. So the first part is conduction defects and disturbances and heart blocks. And this is outlined on page 28 in the course pack. The first thing you want to think about is the normal conduction system. The normal conduction system is, again, you've talked about that in physiology as a prerequisite course, and we looked at that early in this course and looked at that on page 1 in the course pack. And you can redraw it or look at it or think about it in terms of this. We'll be looking at problems that are occurring in the conduction pathway and the conduction system. And you'll have plenty of examples through the course pack and in the PowerPoint material. And we want to take a look at, look through these examples and have you diagnose the EKGs and then also know the criteria for each of these. So if we go forward to the next slide, we have again, under the conduction defects, and you can call these disturbances, the syndrome called Wolff-Parkinson-White, WPW. And this is one where it's some cardiologists, Wolff-Parkinson-White, put their names on it, so you have Wolff-Parkinson-White, but usually everybody just says WPW. And this is where you have an accessory or anomalous pathway. And the pathway is something that goes around the AV node. Usually our conduction goes into the AV node and gets delayed, and then we go through the normal conduction from there. And the AV node delay is something where the P wave finishes, and then you have a little bit of a flat period, and then you go into the QRS complex. If somebody has WPW, they'll have a lack of that little flat area called the PR segment right after the P wave. And what will happen is the P wave will go right into the QRS complex. And the reason for this is that the conduction goes fast around the AV node, and it is you don't have that delay, that normal delay. So the criteria for this then is a short PR interval, less than 0.12 seconds. We said earlier that a normal PR interval is 3 to 5 small boxes, or that would be 0.12 to 0.20 seconds. So it's less than 3 small boxes or less than 0.12 seconds short. It has a delta wave, which is, if you can look on page 29 of the course pack at the top, is an initial slurring point that goes from the P wave in the QRS complex. Instead of going straight into an R wave, it kind of slurs into the R wave. There's it comes up slowly. There's a little curve to it, and that's called a delta wave. There's a prolonged QRS complex, usually not real long, but greater than 0.10 seconds, a little bit wide. And the PJ interval is actually normal because the PR interval is short, but the QRS complex is long, so they compensate for each other. So if you go from the PJ interval, from the beginning of the P wave to where the S wave is going from vertical to horizontal, where there's that inflection point, which is the J point, that interval ends up being the same. There are possible STT wave changes. You can see in the example on 29 on the bottom, there's ST segment depression and T wave inversion, and that can be there at times also. But with these criteria in mind, again, the main thing is to see the short PR interval and the delta wave for WPW. We had a couple of examples on page 29, and if we look at the next slide, you can look anywhere on the EKG. This is the next slide in the PowerPoint. It shows V1 through V6, and probably you just look to where you can see it the best. If you look, for example, in V5, maybe the last beat in V5 toward the right, you see the P wave going right into a slurring QRS complex that's coming up and kind of slanted, and that's a delta wave. So that's an example of WPW. And if you look at page 30 in the course pack, it's in the next slide, we can start to discuss there are three different types of WPW. And it's not real critical to know about these types, but it is important to understand that there are different classifications of WPW. The first one is type A. This is the second most common. It uses, as an accessory pathway around the AV node, it uses the bundle of Kent, and it has a tall R wave in V1 through V6. And if you look on page 30 in the course pack, you see an example of type A WPW tall R wave in V1 through V6. And then type B is the most common, and it uses the bundle of Kent or something called the Mayhem fibers. Again, these are pathways that go around the AV node, and you have a tall R wave in the late precordial leads. In this case, for example, V3, V4, V5, and V6, V3 through V6, the R wave is a little bit high. And this is, but again, you have all the other criteria for this. And then type C is the least common. This is where, again, the bundle of Kent or Mayhem fibers are used. There's a tall R wave in V1 through V4, so that's unusual to have that situation, but it's the least common type of WPW. So that concludes the information on WPW. Again, this is a syndrome or a conduction defect that's caused by having a pathway that is active going around the AV node, and generally that should not be present or active as a pathway, and it leads to a short PR interval and a delta wave, and it's something where the AV node delay has been does not exist. If we go to the next slide, this is a conduction defect that is similar to WPW, and it's called Lone-Ganong-Levine, LGL. Most people just say LGL. And this is shown very well on page 31 in the course pack. There's an EKG at the top that shows a couple of rhythm strips that have LGL, and then a couple of examples at the bottom. They're a little bit, maybe a little bit cleaner to see also. LGL is similar to WPW in that there's a pathway that goes around the AV node, so you have a short PR interval. But in the case of LGL, this pathway conducts right into the conduction system. There's a connection. It's in the pathway. It's called the James pathway. And so because of that direct connection, there is no delta wave. So it's similar to WPW, but it has a short PR interval, but there is no delta wave. So you usually see the P wave just ending, and then an R wave that comes straight up instead of slurring upward on that. And that's a little less common than WPW, but it is something to be aware of. Okay, if we go forward to the next slide, number 4 in the outline, I'll start talking about the bundle branch blocks, or BBB. And the first one is the right bundle branch block. And this you can see on page 32. We'll have an example on the next slide also. And the criteria for this is a tall R wave in V1 with an RSR prime morphology. And that morphology is a kind of a fancy word for shape of the EKG. And that RSR prime, the first R wave, usually indicated with lowercase r, is kind of small, and then the S wave goes below the baseline, and then the second R wave is usually indicated as uppercase because it's large, and it's the second R wave, so R prime is the usual nomenclature for that. There's a wide QRS complex. There's secondary repolarization changes or STT wave changes, especially in V1 and V2. Might even carry over to some other leads, but generally V1, V2. And there's something called a wide terminal S wave in V5. If you look at that example on page 32, you have the classic V1 morphology. That's the main place you should look, with RSR prime and STT wave changes. If you look at V5, there's a little bit, the S wave kind of, it doesn't come straight up, it gaps a little bit. So that's called a wide terminal S wave, and that's not as important as the V1 morphology, is where you really want to look. And right bundle branch block is a blockage or damage on the right bundle of the conduction system. And we'll talk a little bit more about the etiology or cause of this and some of the implications when we start to talk about left bundle branch block. In a few minutes, we'll kind of lump those together. But that's the information on right bundle branch block. If you look at the next slide, you can see this is a perfect setup here. You have, in fact, it's similar to page 32, where the key lead to look at is V1. You can see that there is a RS, R prime in V1. It's wide, has the STT wave changes, and that's a classic right bundle branch block morphology. This might be a good chance to just take a minute to review so far somewhat of a common theme that we've had throughout this course about the R wave to the S wave ratio in V1. And we have said early in the course that the R wave is generally smaller than the S wave in V1. And that's the common or normal EKG. But so far, we've seen 6 examples of where the R wave can actually be taller than the S wave in V1. And it's a good thing to kind of be thinking about as far as a cumulative nature of the course. So again, the R wave should be smaller than the S wave in V1. It can be taller than the R wave in the first case that we looked at was counterclockwise rotation. Could give you an R wave that's taller than the S wave. Another case was a posterior wall MI, where the R wave is bigger in V1. Another case was right ventricular hypertrophy. And then so far today we've added 3 more situations or cases to this: type A and type C WPW, consider that to be 2, and now right bundle branch block. So again, the normal R wave should be small in V1 and the S wave should be bigger. Those are 6 reasons that are exceptions to the rule. And you think of how to differentiate those 6 from each other. In the case of right bundle branch block, you actually have 2 R waves. So that would be a quick distinction from one to the other. Okay, the next bundle branch block to look at is left bundle branch block. Again, this is a conduction defect, and it's shown on page 33 in the course pack. This is something that's fairly easy to see because it has, as far as the criteria, a double R wave in V5 and V6. And they're both usually fairly large, these R waves. And it has what's called a rabbit ear morphology. So if you look at page 33, especially V5, V6 has a little notch in it, but V5 has the classic 2 R waves, double R wave, or what they call, again, rabbit ear morphology, rabbit ears in V5. There's actually a kind of an enlarged version of that right next to the number 33 on that page. It also has a wide QRS complex, usually greater than 0.12 seconds, which would be greater than 3 small boxes throughout the EKG. Secondary repolarization changes, or STT wave changes. Again, that means ST segment depression, T wave inversion, usually found in leads 1, AVL, and then often V4 through V6. Now, in the example on page 33, it's just V5, V6, and 1 in AVL, so it's could be most of those leads. There's no septal Q wave in 1 in AVL and V4 through V6, and you can see that again on page 33 in the course pack. And the reason for this is that the left side, the left bundle, is blocked or damaged, and so it's being a little slower to respond. You cannot have a small or septal Q wave in those leads. And so those are the criteria for left bundle branch block. That's a good example on page 33. If we go forward to the next slide, you can see another example, and especially if you can look at V5 and V6 and see the rabbit ears and the wide QRS, and then especially V6, it has some STT wave changes. And this is just a partial 12 lead, V1 through V6, but you can see the left bundle branch block fairly clearly. This is one that's pretty easy to see, and something that again kind of stands out. If you look at the next slide, I want to talk about the bundle branch blocks and the etiology and implications. And usually for the bundle branch blocks, there has been, maybe there's coronary artery disease or blockage of blood flow that goes to that area. Maybe there's been an infarct that's damaged that area. Maybe it's a part of the aging process or degeneration process of the conduction system, or sometimes it just happens. It's unknown. But the implications for them is that it makes it difficult to interpret for the EKG for further reading, like ischemia and infarct. And especially in the case of left bundle branch block, there's generally a standard where if you are doing a reading of the EKG or the EKG reading system, when you get to the point of seeing or making the diagnosis of left bundle branch block, you really cannot read the rest of the EKG. You just have to say, this is what I see so far, and later in the course we'll look at a system for reading the EKG, but this is what I see so far, and then you would write or say left bundle branch block is present, therefore I cannot do any more interpretation of this EKG. It kind of stops the interpretation. Some major implications for this for an exercise science student is that it makes it, the bundle branch blocks, especially left bundle branch block, make it difficult to interpret ischemia and infarct on the EKG. And so if we were doing an exercise test to make an interpretation of ischemia, we, and the person has left bundle branch block, we do not want to rely on the EKG. We want to use, do a nuclear test where we inject a dye into the person and we visualize, the different parts of the heart and visualize the amount of blockage that way instead of using the EKG. So if you have a patient with left bundle branch block, they generally will have a nuclear imaged exercise test as you start to, as you look for the diagnosis of ischemia. So that's the information on bundle branch blocks, and I think one good thing in that area is they're fairly easy to see on the EKG, and they are fairly distinct from other things and from each other. Okay, the next area to look at under conduction defects or disturbances is the area of hemiblocks, often called fascicular blocks. And if you think of the conduction system, the left bundle has two halves. It has a left anterior part and a left posterior part, and you could have damage or blockage to either one. And the first one that we want to look at is what's called left anterior hemiblock, LAH, or left anterior fascicular block, LAFB. And this is where you have damage, again, to that one part of the left bundle, that one half of it, or hemi. And if you look on page 34, we have an example of left anterior hemiblock and the criteria listed on this slide. Generally, this is called based just on axis deviation, left axis deviation greater than -30, in the absence of LVH and in the absence of an inferior wall MI. If you have, those things can give you left axis deviation, but if you have left axis deviation and it cannot be explained, then generally you make the call of left anterior hemiblock, left anterior fascicular block. So if you look at that EKG on page 34, and you could try this on your own, maybe pause and do the axis. If I do the axis on this, I see that pretty much everything is either up or down in 1, 2, 3, R, L, and F. AVR would be the best choice for isoelectric because it has part of it down, part of it up. It's a little more up than down, but it's somewhat, at least compared to the rest of them, the most isoelectric. Perpendicular to AVR is lead 3, and that's completely down, so that puts the axis at -60. There is no LVH, and there is no inferior wall infarct. So this is axis deviation in the absence of those other causative factors of axis deviation, and it's left axis deviation more than -30, and that means more negative than -30, so in this case -60, and therefore I would call this left anterior hemiblock. This is often associated with an anterior wall MI because the anterior wall MI can damage that particular fascicle because that's where it's located. The next hemiblock or fascicular block, again, is part of the left bundle, and this is the posterior fascicle. And so it's called left posterior hemiblock, LPH, or left posterior fascicular block, LPFB. And this is on page 35 in the course pack, and this is where you have right axis deviation greater than -20 in the absence of RVH and in the absence of a high lateral wall MI. Those RVH and high lateral wall MI are items that cause right axis deviation. So if you can't explain the right axis deviation, then you would make the call of left posterior hemiblock. If you look at page 35, a good choice for isoelectric would be lead 2, and therefore AVL would be perpendicular and AVL is down, so that would put the axis at positive 150. If you did consider AVR as a choice, and you look at lead 3 being up, that would be 120. So I would say this axis is somewhere between 120 and 150, but probably closer to 150, and therefore you have right axis deviation in the absence of RVH and in the absence of a high lateral MI. So the diagnosis on page 35 then is left posterior hemiblock. Now we want to shift forward to something that is under this category of conduction defects, but it's a specific area called heart blocks or AV blocks. And these are blocks that are usually seen better by looking just at rhythm strips instead of a 12-lead EKG. And actually our next area, dysrhythmias, is mainly a rhythm strip diagnosis also. So a lot of electrocardiographers prefer the using just a rhythm strip. It's kind of easier to see things as opposed to a 12-lead, but you have to do a combination of things. But for a while we'll be on mainly the idea of rhythm strips. The first AV block is called first degree AV block, and there's a single criterion, just one thing, and this is a PR interval that's greater than 0.20 seconds or greater than 5 small boxes. If you look at the example on page 36, you can see several examples, A, B, and C, to start, that have PR intervals that are long, and the numbers are given 0.25 on A and 0.57 on B and 0.90 on C. The P wave on C is actually just after the T wave of the preceding beat, and you have this very, very long PR interval. So those are real long, and then there's a nice clean example at the bottom with a long PR interval. And again, that's to diagnose first degree AV block. That's all you need to have is that long PR interval. If you look at the next slide, again, the PR interval in this case is well over 5 small boxes. Looks like it's in the area of pretty close to 7 small boxes. So you make the EKG diagnosis of first degree AV block. And in fact, it has done the math for you and put that at 280 milliseconds, which would be the 7 times the 40 is the 280. So, but again, I kind of think in terms of small boxes, and 7 is long, and that's first degree AV block. Another type of AV block is second degree. And with second degree AV block, on the next slide, is you have 2 possibilities. You have second degree AV block, Mobitz 1, or called type 1, or sometimes called Winky-Bach. And that's just 3 different names for second degree AV block type 1, 3 different ways to say it. The criteria for this is shown on page 37 as far as an example EKG and criteria listed on this page. You have a progressive prolongation of the PR interval, and we'll look at that in a second. The P to P interval is constant. You have dropped beats. You have grouped beating. Groups, it looks like groups like the footprints. Sometimes it's called the footprints of Winky-Bach on the bottom of page 37 because of the gaps in the EKG, and the gaps are indicating drop beats. But really the main place to look is at the top of page 37, where it has an EKG and has 1, 2, 3, 4 like that. You have a PR interval on 1 is kind of a normal distance, and then It gets longer on 2, longer on 3, and then the fourth P wave does not conduct a QRS complex. So that's a dropped beat. So you have that idea of PR interval, longer, longer, longer drop type of thing. And that's that progressive prolongation of the PR interval. You'll have a lot of examples of this later in the course, later in these sections, and that prolongation is what you're looking for on that. If you look to page 38, there's another example, and you have a beat to the far left at the top, and then you have a P wave that did not conduct a beat, and then if you go to the second R wave over QRS complex, you have a P wave with the QRS complex where the PR interval is normal, and then it gets longer, PR interval is longer, and then a P wave by the arrow where you actually have no conducted QRS complex, a drop beat. So that's that progressive prolongation with dropped beats. And then where the arrow is right below that, too, on that other EKG, you can see a P wave that did not conduct a beat, and you can follow the pattern after that again with a prolongation of the PR interval until a beat is dropped. So second degree AV block, type 1, also called Mobitz 1 or Winky block, has that characteristic lengthening of the PR interval and then dropped beats on there. If we look forward or look to the next slide, you can see another example of this. And if you look to the far left, you have a PR interval that is close to normal, maybe a little bit long, and then you go longer, longer, drop. And then back to where reset to close to normal, longer, drop like that. And you have that lengthening PR interval. So that's another good example of Winky block or second degree AV block type 1. There's another type of second degree AV block, and if you go forward to the next slide, this is second degree AV block type 2, sometimes called Mobitz 2. And this is similar to type 1 in that you have dropped beats, but it's different in that you do not have the prolonged PR interval. So the criteria would be a constant PR interval, constant and normal, and then dropped beats, where the dropped beats means where the QRS complex is not conducted. Page 39 in the course pack shows to the far left there's a P wave with a drop beat, but if you start with the next beat, you have P wave QRS, P wave QRS, P wave QRS, all with normal intervals, and then where the arrow is, you have a P wave with no QRS, a dropped beat. And then similarly at the on the bottom EKGs, you have these PR intervals that are not lengthening, and you have P waves that do not conduct beats, drop beats like that. So like second degree AV block type 1, you have dropped beats, but unlike second degree AV block type 1, type 2 has a constant PR interval with the drop beats. And then another example is on page 40 in the course pack, and this is something that has a situation where you have multiple P waves for QRS complexes, and you have like in the first one, every other beat is dropped, and then in the second one down, every third beat is dropped. It's an EKG that I wouldn't make testable because I don't want to put in that multiple situation. But generally, let's look at another example on the next slide. Generally, you just look at a PR interval. It's normal. PR interval is normal, and then in this case, you have 2 drop beats in a row, and that can happen. And then they're dropped, and then you're back to a normal PR interval, normal, and then a drop beat like that. So again, back to the criteria slide, you are just looking at no lengthening of the PR interval, but occasional drop beats for second degree AV block type 2. The significance of these second degree AV blocks, again, they have drop beats, so they're not something that you necessarily want to have, but they're generally reasonably stable rhythms. And what would happen is you would refer the patient to the cardiologist, and the cardiologist would consider putting in a pacemaker for these if he or she thinks that's the way to go, or maybe they would monitor it for a while. But generally it's fairly stable, and the patient might end up with a pacemaker. If we go forward then to third degree AV block, this is also called complete AV block. And in this case, the criteria is no association between the P waves. P waves are atrial depolarization, and the QRS complexes meaning ventricular depolarization. So no association between P waves and QRS complexes at all. P waves are beating at their pace, and the QRS complexes are beating at their pace. The P wave pace, the atrial rate, is faster than the ventricular rate. And on page 41 in the course pack, we'll have a couple of examples. You have P waves that are going along, P wave, P wave, P wave, and then another one, and then there's one that's lost in the QRS complex, and then another one like that. P waves are going on their rate, and the QRS complex is going at a slower rate, but they're not communicating at all with each other. And so therefore, and you can see the next example down too, you have a P wave. This is the middle EKG on page 41, P wave, and then a P wave that's kind of lost in the T wave, P wave, P wave, P wave, and you can kind of go through and see where the P waves are. One of the things that makes this fairly easy to see is the idea of lost and found P waves, where you can you see them and then they get lost or absorbed basically by the QRS complex. If you look at the next slide, you can see at the top, and we'll come back to the previous slide in a second, but you have a P wave to the far left, and then another one, and then another one that's kind of right after the QRS complex, and then a couple more in the middle of beats, and then you have one in the QRS complex. So once again, you have that lost P wave, and again, what's occurring is that you have P waves that are lost and found kind of throughout the QRS complex, and the P wave rate is faster, QRS complex rate is slower. This is the clinical implications of this is that it's always corrected with a pacemaker. Patients in third degree or complete AV block will always get a pacemaker implanted to take over the initiation of their heartbeats. And so if you look at page 41 at the bottom, you can see that there's a kind of a spike straight up and down line before every QRS complex, and that's the pacemaker pacing the beat. That pacemaker is actually pacing right in the ventricles and initiating that heartbeat right in the ventricles with that spike that causes that to happen on the bottom of page 41. So that concludes Module 3, Part 1, and that concludes everything on the conduction defects or disturbances in heart blocks. And we will now move forward to Module 3, Part 2.